So thank you for attending again. I think we've had a good discussion with regard to the sixth of the 10 commandments, you shall not murder. Yesterday, I was talking to someone who attends this class, and he said, I didn't know you could expand this commandment into things like abortion and euthanasia, because most of the time we preach, when we preach on this topic, we take Jesus's application in Matthew chapter 5, which talks about, you have heard that it is said you shall not murder, but if you are angry in your heart. So we dealt with anger in the first session. In the second session, we had abortion, and now we're going to deal with euthanasia. Now, when euthanasia came, at least medical assistance in dying was approved in 2016, and it kind of became the law of the land. There was an article in Maclean's in 2018, which talked about this issue and looked at it in a more critical manner. And this, we are talking about the secular world, right? The article, I'll quote a bit more at the end, but here, just to say what the headline was. The headline was this: assisted dying was supposed to be an option. However, to some patients, it looks like the only one. That means the only option. And Peter Strickland goes on to say that ambiguity around Canada's law has reduced the decision in many cases to the personal judgment of doctors, or to patients with no access to palliative care, right? So you see there's two aspects here. It becomes the personal subjective judgment of doctors, or if the patients have no access to palliative care, they think the next best option is just to die. So is this biblical, and how are we going to think about it biblically? So as we know, this comes under the sixth commandment, which is you shall not murder. We look at both the 10 commandments in Exodus 20 and Deuteronomy 5. This commandment does not have any additions or subtractions based on the two accounts. So in the first class, we did the personal application, which is anger. Then last week we did abortion, and now we're going to do something that has both a personal and a societal application, which is euthanasia. I'm using an older word, but basically all these new words encompass the same concept. So what is euthanasia, or medical assistance in dying? How can we define it? At one point in time, I'm ancient enough to say that we used to use the word mercy killing. Mercy killing or euthanasia, or whatever word you would like to use, translates usually as a good death, right? It's spun in a positive manner, and basically refers to the act of painlessly but deliberately causing the death of another person who is suffering from an incurable, painful disease or condition. So it's trying to deliberately cause the death of somebody who is suffering, but trying to do it painlessly. I want to go through some terminologies quite quickly so that we have a term of reference as we talk about this. Active euthanasia is generally understood as the deliberate action of a medical professional or a layperson to hasten a person's death, right? So a medical professional actually hastens a person's death. Passive euthanasia is different. This one is letting a person die. That means the person is dying naturally. And so the patient's death is not due to any actions taken by the medical profession, but actions that would normally keep the patient alive are not offered. So that would be a kind of passive euthanasia. Then we have voluntary euthanasia. That's when somebody requests to die. So that's like a voluntary suicide. I want to die. So he tells the professional, I want to die. Then there is non-voluntary euthanasia, which is much more common than you may think. This refers to when a patient is unconscious or otherwise mentally unable to make a meaningful choice. between living and dying, and a legal surrogate makes the decision. Sometimes the medical professionals. It has been found that in Europe, particularly in countries which legalized medical assistance in dying some time ago, there was a significant number of non-voluntary euthanasia, where patients actually had never indicated desire not to be kept alive, but the professionals made a decision that, well, this we will just withdraw treatment. So that's non-voluntary euthanasia. And then there's, of course, involuntary euthanasia. Now, this is one thing I want to talk about. Futile measures generally refers to the medical care of patients in which the care will have little or no effect on the patient's outcome or prognosis. Futile measures is a challenge for medical professionals, and I'm going to give you a couple of examples from my own life. I've seen death over the last, I've worked for over 40 years in medicine, and probably the most striking times when I've seen futile measures have been when I went to Africa. So two particular incidents stand out in my mind. The first is a child in Angola, in Lubango, Angola, where I went to do the orthopedic surgery. And at the end of the day, around 8 p.m., done the surgery, there were two residents, or very young residents, one from Germany and one from the USA, assisting. And they were called to the emergency, and I went off to the tea room, and all of a sudden they called me and the resident doctor. The resident means he's an American surgeon who set up that hospital. And there was this 3-year-old child gasping for breath in the emerge. And the mother, of course, was crying outside. And the two girls, the two residents felt, they really felt they wanted to resuscitate this child. The diagnosis was cerebral malaria, and the child was too far gone. I realized it because I saw the type of breathing that the child was having, that she was in the last stages of dying. Of course, the resident surgeon in Angola sees this all the time, and he kind of told me, yes, it's really too late. Whatever we do, we're not going to be able to save this child. And of course, we're in the middle of the bush, 500 kilometers away from, the largest town. And so we're not going to waste our scarce resources. But the two girls were very, they were just overwhelmed, and they felt that they had to do it. And so the surgeon said, yeah, why don't you carry on? Because, we all have to learn. And so they tried to resuscitate the child. They spent half an hour with cardiac massage, intubating the patient, injecting all kinds of medications, but the child, of course, died. So that's one example of futile measures. We kind of saw the patient, we figured that the patient is going to die. And the two of us who were more senior, we felt, well, it's not going to help. The second one happened in Gabon in Bongolo Hospital, which is where I went in 2006. This happened, I think, in 2006, and I was the only orthopedic. The resident surgeon had left, and so he got a locum surgeon from the States. He was about in his mid-70s, and there I was, the orthopedic surgeon, and we had to do even the cesarean sections. But one night I'd finished my surgeries and everything, and I was just so tired, I went to bed. And around 11 o'clock, they called, and they said there was this man in the emergency with a bad infected leg. I go down to the emergency, and everyone is outside. No one is inside with the man. And I asked, why is no one in there? And they said, there's such a bad smell. No one can go in. So we triple mask and we go in, me and the resident. There was a resident there with me from Chicago, a young surgeon, and he bravely came in. And we looked at this man, and there were this severely infected leg. So he had fallen in the jungle and injured his foot, and it got infected. He went to a native medicine man who had put some kind of leaves on it, and the whole thing became so badly infected, the infection came up all the way to his hip. and the whole leg was kind of so smelly. And there were these huge, huge flies, which hang around. The flies were about the size of half a golf ball. I mean, it was just a terrible situation. We were almost nauseated. Looked at the man, he was in renal failure. He had not passed urine for 2 days, which means he's terminal with regard to renal failure. And of course, again, the young resident says, we must do something, we must do something. And the anesthetist comes in and says, I can't give you anesthesia for this. We can't, he's too terminal. So again, do we do any futile measures? This young man is so insistent. The American surgeon said, no, I can't do anything under general anesthesia. So back home, I had done above knee amputations by local anesthesia. So since he was so insistent, I said, okay, let's do it under local anesthesia, but I'm telling you, this patient is probably not going to survive. But because you have such a passion for this, and we'll do it. And then we go outside and the lady says, can you pray before you do the surgery? So yeah, we prayed, and we went in and just kind of did it under local anesthesia, which means we had to cut the leg off within about 10 minutes and quickly. And I finished the surgery and I left the patient in the hospital, and I went back and just flopped into bed. But this young man, credit to him, he just stayed with the patient, he observed him, he tried to give him some fluids, whatever. And I fully expected to wake up in the morning to hear that the patient had passed away. But he hadn't. The next morning, he was still alive. And I said, wow, Lord, sometimes you don't give man enough knowledge about this. When is a person supposed to die? And it opened my eyes to this idea of futile measures. Can doctors really decide when it is futile and when it is not? And I left Angola about a week later. Patient was still alive, and I received some emails. He had finally been discharged well. Even his kidney function had come back. So 2 cases, very stark in their diagnosis. But it tells us something, that there's a lot of ambiguity when we talk about futile measures, right? In trying to save a person. And therefore, I think ambiguity around Canada's law has reduced the decision in many cases to the personal judgment of doctors or to the patients with no access to palliative care. And this may not be a good thing because we don't have an objective standard by which to stand on. And this particularly affects people who are in a persistent vegetative state, right? The National Institute of Neurological Disorders and Stroke says that patients in such a state have lost their thinking abilities and awareness of their surroundings, but they retain non-cognitive function. That means things like breathing, they can move, and they have normal sleep patterns. The only thing they don't have is cognitive functions. They cannot speak or communicate. Now, the rest are there in your notes for completeness. I'm not going to go through that, but you can look at it and think about it as you go through. And there are various things we can do to kind of keep people comfortable in terminal care. And that's what we would call palliative care. Now, euthanasia, therefore, is a burning issue today because there are Christians, as we have seen, almost 100% of us would say that we should leave it to God. But society has changed in a very dramatic way, in the method that it uses to view disease, suffering, and old age. Old age, in fact, becomes a disease almost. And since medical assistance in dying became legal in Canada, you can see how it has grown. I have figures until 2019. You can see that it started off with about 510 and up to 2,614 in 2019. You will see that the vast majority want the doctor to kill the patient, to kill them. Self-administration seems to be very, very poor. If somebody has expressed a desire to have medical assistance in dying, and we say, well, here's the medicine, you do it yourself, they don't seem to want it. They want to, they want the doctor to do it, which creates a dilemma for the Christian doctor or any doctor. Recently, Pope Francis, at least for the Catholic Church, they have kind of one voice. He condemned the unacceptable drift towards euthanasia, characterizing efforts to deprive the terminally ill of the necessities of life. So here you see depriving the terminally ill, right? Thinking it's futile. And he says it's neither human nor Christian. And he suggests that the idea of palliative care that enables every person who's preparing to live the last stretch of their life to do so in the most humane way as possible. So many churches, unfortunately, we are so diverse and there are so many different churches, we don't speak with one voice, but it is maybe helpful to have a universal biblical ethic that we can kind of express as one voice. That do not murder includes do not abandon the ill and the infirm to an early death. That, as I mentioned, the thought of suffering in old age suffering is now almost thought of as a disease, and it's affecting Christians as well. The comfortable thinking, Christians want a comfortable life, and any discomfort, any suffering is thought of as too troublesome, particularly in old age. And so we have trouble accepting the weakness and helplessness that may come with old age. And even Christians, as I mentioned before, have written some articles that say that it is justified to take the power to decide on themselves and not just leave it to God. And legislation today has opened another slippery slope, which is from euthanasia, which is like medical assistance in dying, to almost an obligation to die, in the sense that society looks at older people and those who are infirm, those who drain medical resources. They feel that, why don't you just take assisted suicide so that these medical resources can be used elsewhere? And this is entirely true. When I have a lot of patients over the age of 70, because I see a lot of patients with osteoarthritis of the knee and hip, and I can see all the other ailments that they have when they come to see me. And sometimes they use lots and lots of resources. They have hundreds of tests, many imaging scans, all of which cost a lot of money. And so there may be unseen pressure to influence the elderly to ask for medical assistance in dying. And as I mentioned to you earlier, involuntary euthanasia, studies have shown that in Netherlands, many elderly and infirm actually have been euthanized without their explicit consent. They were just old, infirm, and some medical person felt, I'm going to take them out of their suffering and either inject extra morphine or inject some potassium chloride, all of which can kill the patient quite quickly. And when the patient is old and infirm, everybody thinks that they died of old age. In 1990, it was said that about 6,000 deaths in the Netherlands was euthanasia without explicit consent. So you can see how the slippery slope can go to mercy killing by professionals who think that they want to put the patient out of their misery when the patient himself or herself does not want to do so. There is a law now in Arizona, which is sometimes called Jesse's Law, but it's named after a person called Jesse Ramirez, who was in his SUV and they were driving, and he was quarreling with his wife. They were actually on the verge of divorce and they had a bad quarrel. They ran off the road and he was severely injured. He ended up in a coma in May 2007. And of course, his wife, who was going to divorce him anyway, requested that food, water, and antibiotics were withdrawn from him. This is called the removal of all the nutrition and hydration. Now, the Christian Medical and Dental Association does have guidelines on this, but basically the family, especially the sister of Ramirez, went to court to fight this, because she said the wife obviously was going to divorce him. They were quarreling in the car. After the crash, he was in a coma. She was fine. And so she decided to withdraw and let him die. But the court decided that, and this is what the court said, feeding must continue during the legal process if there is a challenge to a guardian, right? So the guardian was the wife. The guardian's decision to remove a feeding tube from the incapacitated person. And the court will have to make two findings to stop the feeding: that it is clear and convincing evidence the incapacitated person showed some intent. He wanted to be off the feeding tube in such circumstances. That means he had given some kind of advance directive. And a neurological examination, that is by a doctor, would show that the person is in an irreversible coma or persistent vegetative state that is not curable, right? So while this court case was going on, guess what? Ramirez, who broke his back, neck, and forearm and suffered massive head injuries, actually recovered. And he recovered. He has cognitive awareness. He is able to talk. He's able to communicate. And if he had been left without food and water, he would have died. And in an interview with East Valley News, he said he is grateful to his family for fighting for him. That's in 2009, long after the accident. So, advanced directives. Remember, the court case said, did this person show any kind of advanced directive as to what should be done if he was in a coma, right? So an advanced directive lets people state their wishes for end-of-life care, especially if they become unable to communicate their decision. And this usually means to remove artificial life support. Does not always mean remove nutrition and hydration. And the rationale is that the courts or society or the doctors, they want you to specify what you want to happen in case you cannot make a decision. And usually to avoid being kept alive for months and years by artificial means. So you and I as Christians, to think biblically through this, we got to ask ourselves, is this a decision we can make at this time? I could make an advanced directive that says, well, if I'm on a respirator, please remove me. Now, in the times of COVID, as you know, in the last 2 years, some people ended up on a respirator within a day or two. They didn't even know that they could end up on a respirator. And some of them have been on respirators for 3 months, 6 months before they recovered. If they had given an advanced directive to remove life support, when should that be? So it's is this a decision that we can make with any clear information at this time while we're still alive? Or is it becoming a form of medical assistance in dying, that we're kind of saying, well, if that happens, I would rather have an assisted suicide? Can we determine what the criteria should be? And so that's the problem. Even as a medical professional, I find it so hard, right? But imagine for the ordinary person, how do you specify in advance what to do in every complex medical situation? So an advanced medical directive sounds simple, but the actual issues can be quite difficult. So another concept has come in more recently, which is the durable power of attorney. The durable power of attorney places the emphasis on the relationship of trust and understanding between the patient, family, and the physician, because the trust that is placed on either the relative or the physician gives that the decision to the relative. So in most of the time, if it's a Christian couple, the trust is given to the spouse to make a decision as to what the person would have wanted in that situation. The biblical principle, therefore, would then be do unto others what they would have them do unto you. Sorry for the typos there, but it's basically do unto others what you would have them do to you. So if your spouse is lying in the bed and in that situation, put yourself in that situation, think about all the years you spent together, all the time you spent praying, thinking about the Bible, spending time in relationship with God, and then make that decision from a biblical point of view. And the biblical point of view, of course, is that the Christian will die when God chooses to take him or her, and therefore to trust a godly relative or physician, especially in situations where there is no reasonable hope of recovery. You have seen that this futile measures situation can go either way. But there are situations where there are no resources to prolong life that is vegetative. So if I was in the middle of Angola or Gabon again, there could be some situations with COVID where you just don't have a respirator, you don't have an artificial life support. In that case, you can't do anything, right? So durable power of attorney may be better than an advanced directive, because an advanced directive can then empower the physicians to say, well, he gave the directive to, that if he was vegetative, we're withdrawing life support, even when the spouse disagrees, right? And so the Christian doctor, so that's the patient kind of perspective. But what about the Christian doctor? I know this may not make such a difference to you, but maybe it's helpful for you to think how a Christian doctor has to think, right? What is the difference between actively killing someone or letting someone die, right? So that's basically it, right? Even when I was a med student, we had this debate, and we had a very godly professor of psychiatry, and he wrote an amazing article in the Christian magazine back home, and my thinking has always been in the direction that he articulated, which would be well, I'll mention it maybe in the Q&A, but we'll talk about the two options that a doctor needs to think about. Do you actively kill someone, right? Killing is actively doing something to a patient that hastens, not hastens, hastens or causes his or her death. The cause of death is the action taken by another person. So in this situation, we could actually say that the Bible, this commandment, you shall not murder, actively prohibits killing someone. But letting die is probably a different thing. This is a passive situation where you allow someone to die from other natural causes, or just, as a consequence of the illness, without interfering with the process. And the cause of death will, of course, be the disease or the injury or the aging process already occurring in the person who dies. And in this situation, from a biblical perspective, active treatment then presents a challenge to the Christian doctor, right? Like, do we afford the treatment? So when we have the opportunity, as I mentioned, when you're younger, you're more passionate, you want to save more people. There were, as I mentioned, 2 young residents in Angola, 1 young resident in Gabon. As a senior doctor, I was wrong once and right once. I mean, well, actually, maybe I was wrong both times. I don't know, right? So that's the issue. But do you give active treatment when you're not sure whether the measures are going to be futile or not? So I think I've now come on the side of, when in doubt, do it, especially when there's no other directive available. But I think, therefore, it is clearly wrong to let a person die if he can be saved for a purposeful life. And that, of course, we won't know, only God knows. What kind of interventions can be available where we are trying to save somebody for a purposeful life? Basically, providing nutrition and hydration, I think, is not the same as an artificial life support system. Remember, providing nutrition and hydration is usually to a patient who has still got non-cognitive functions. That means they can still breathe, they can still move, but they don't have cognitive functions. That means they cannot talk to you. You may not think they hear you, but it's possible they could be hearing you, but they're not able to communicate. So you need to provide nutrition and hydration for these kind of patients, because it's not the same as artificial life support where they've got a tube down into their lungs to respirate them, right? So artificially administered nutrition and hydration can be an issue that Christians may disagree about, unfortunately, because it often presents the doctor with the dilemma, right, to make a decision. And I have no time to unpack this whole thing, but if you're interested, you can go to the Christian and Medical Dental Association statement on artificially administered nutrition and hydration. And it's on that website. I've given it to you in your notes. So I would suggest that intervention is likely indicated if there is reasonable hope for human recovery, and if we are able to offer that hope. If you're in the middle of Africa, you may not be able to offer that hope. If you're in the US, Canada, you obviously can, because there are many resources. But of course, if you are, say, in a smaller town, by the time you get the person to a bigger town, the patient may have succumbed to the illness. That's, again, a situation where you are not able to offer the help. And I think the principle to look at could be the parable of the Good Samaritan, which is the difference between being left to die, where the priest and the Levite decided that, well, one, he's a Samaritan, but of course, that they thought that he was just going to die. Or being helped by a stranger who actually did something active to try to help the person to recover. Interventions may not be indicated if there is no reasonable hope for recovery and it's a futile situation. And again, I've explained to you that after 42 years as a doctor, I still don't know what exactly could be a futile situation, but I think the Lord knows, and whatever decision I or a fellow Christian doctor makes, the Lord will superintend that decision. Or intervention may not be indicated if it is the patient's wish to be left to die of the natural causes of the illness, the natural consequence of the illness. For example, if they have terminal grade 4 metastatic cancer, which has gone to the brain, gone to the liver, gone to the lungs, no treatment is going to help. So if it's a patient's wish to be left to die, that intervention may not be indicated. And lastly, of course, if we are unable to help, right, we don't have the resources to help. So in conclusion, I think we discussed this many times already, particularly in the theology of man. That class talked about death, and we also talked a little bit about eschatology. So we don't need to fear death because our life is in God's hands. And the Bible has a lot of stories about people who just yielded their lives to God. When it was time to go, they just said, Lord, yes, take us. One of the things that often strikes me is Moses, right? He was there, and when God said, you're going to die on this side, and you're not going to cross over into Canaan. And he just accepted that. He goes up to the mountain, and it was time for him to die because they just yielded their lives to God. And I think Christians have this settled disposition about death, that if God takes us, it is time to go. We have our eternal hope of life in heaven with him. I would say that the direction that society takes or is taking or has taken on the question of euthanasia is a reflection of how it values human life and how it values God's command not to murder. And I think from a Christian perspective, I think that's where it comes down. The commandment, you shall not murder, actually boils down, as we saw last week, to abortion as well, is how much do we value human life? Life that is made in the image of God. God is the one who takes life. God is the one who gives life. And God commands us not to murder. So lastly, I think we need to value our elderly, as medical assistance in dying is becoming more and more common now. The modern trend has set the stage for further erosion of the protection of human life. And some people will be thought of as too old to deserve medical treatment. I was in Toronto, and this maybe was about maybe 15 years ago, I think. It was I got a call at 2 a.m. from one of our church friends. He was in my alpha class, and he said my mother. He was in his 60s. His mother was about 90 in the hospital. She had just had hip surgery for a broken hip, and he said she seems to be going away. Can you come and have a look? So I go into the hospital and I go up to the ward and I just say, I'm a friend. I went to see her. And there she was, kind of gasping away, and the drip had been turned off. This was a case of involuntary euthanasia. The nurses and I think the doctors had just thought that she's just way too old to save. They had turned off the drip. I looked at the drip and I said, why is the drip not running? And I called the nurse and she said, oh, and then she gave me some kind of story and they restarted the drip. But according to my friend, after I went home, something happened to the drip. It got stuck and they didn't reset the drip. And of course, she passed away after a couple of days. So sometimes I think the medical establishment in the hospitals are beginning to think that some people are too old to deserve medical treatment. Compassion and care for the elderly will diminish, but they will be, because they are thought of as a burden to be cared for rather than a valuable member of society. And you know, all of us, if we live long enough, will ourselves one day be the elderly people who need care and support. And so how we think about our elderly is how we should hope that people will think about us when we become the elderly people one day. So let me conclude by reading some excerpts from that McLean's article. Again, it's a secular article, but it tells you, it helps us think biblically through this. So it says, Canadians were asked in 2016 to ask what is now medical assistance in dying as a standard practice in the healthcare system. But as the second anniversary of the federal law sanctioning assisted suicide passed this month, ambiguities embedded in the new regulatory regime are turning end-of-life care into a troubling leap of faith for doctors and patients alike, right? A troubling leap of faith means very subjective decisions. Even the Quebec College, right, which sped ahead with its own statute in advance of Ottawa's Bill C-14, has sounded a strong warning note about patients choosing to die by suicide, right? Medical assistance in dying, purely because their preference for palliative care isn't available. So these are older, elderly people who look for certain types of palliative care. They want to live, but they cannot find proper care. And so they choose, okay, let's choose to die. And so Dr. Charles Menard, he says, you know, end-of-life care cannot be limited simply to medical assistance in dying. And this is, of course, you know, Quebec, which is quite secular in this sense. And he wrote to the provincial health minister and said that option makes no sense from a medical point of view unless it is a part of a robust and complete system of palliative care in Quebec, and I would suggest in Canada. I would also suggest that as per the Bible, I think it is important that children do look after their parents in their old age and make sure that they provide all that they need in their elderly years. So we finish with some questions to ponder. And those are in your notes, right? Have you discussed or talked about your immediate family, about wishes with regard to end-of-life care? And what provisions and instructions have you put in place? You know, it doesn't matter what age you are. You could be 30, 50, 70, 90. But I think death can come at any time. Disease can come at any time. As you saw, Jesse Ramirez was only 27 when he had his accident. So we need to have some provisions in place. But do you think this is important as a Christian person? Or do you think you should just leave it to the Lord? Do you think you should have some kind of decision, a godly decision maker for yourself, rather than you trying to decide what to do now when you're not aware of what's going to happen in the future? So I leave all these questions to you. It is something that needs a lot of thought.